Thank you all for tuning in to listen to this talk. So we're going to be talking about neurological emergencies tonight. So thank you for CPD for inviting me back after the previous talk, and hopefully you'll find this useful. So let's begin. So obviously, hello, my name's Chris. I work as a clinical teacher in neurology and renal medicine for a medical school in the Northwest. So I'm speaking to you from Lancashire at the moment. Thank you for all of those that sent in some feedback after the last talk. It was great to read, so you can always send your comments, you can email me, or you can send your thoughts to CPD. I kind of feel like we're getting to know each other, so even though I can't see or hear you, if you came to the last talk, it's good to have you back. I did, however, realise I made a very important mistake in the last talk, which is I didn't include a picture of my dog. So this is Maggie, and she makes appearance on all of the presentations I give. She's showing off her favourite ball here at the moment. So yeah, sorry about that. So all future presentations will of course have a dog photo. So maybe if some of you are doing selfies, then you can include photos of any pets you have around. So let's think about what we're going to talk about tonight. So I'm going to focus more on kind of neurological emergencies and think about things from a medical point of view rather than going through lots of trauma case studies. And the reason for this is that neurological presentations can be really challenging to assess and manage, whatever skill level you are practicing at. And the other problem is that there's a lot of common neurological complaints, and two that spring to mind are headache and back pain. So if you go to an emergency department, urgent care centre, if you're working pre-hospitally, etc., these are very common complaints, and I'm sure most of us have had headache or back pain at some point in our lives. And the other problem with neurology is that the neurological examination can seem very daunting. So I'm aware that there's lots of different skill levels and people with differing scope of practices listening to this, and you might have been taught different levels of neurological exam. So in this webinar, we're going to keep it relatively simple, but there are some excellent online resources if you want to improve your neurological examination skills. So those of you that came to the last session, you will have experienced the case-based format. So I've reduced the number of cases for this session. So we've got 3 cases to discuss. And we're not going to think too much about clinical reasoning, although we will touch on it. But obviously, as we go through the cases, have a think about differential diagnoses. So you can share these with me in the question box. So if you just type in your thoughts about what the differential is, I'll be able to see it. Or if you just have a pen and a paper at home, it's quite good just to note down some thoughts as we go through the cases. We don't have a lot of time, so I'm not going to be able to dwell on them. But if you're listening to this as a recording, you can always pause the video, and if you need a bit longer to think. Right, let's get started with our first case. I haven't made these too complicated because I want to spend longer thinking about the underlying diagnosis. So case 1 is a headache, very common. So let's explore this a bit further. So this is a 46-year-old lady. So she describes a sudden onset headache that came on about 4 or 5 hours ago. So she did what lots of sensible people do and took some paracetamol, but it didn't really get any better. It's now uncomfortable to have the lights on, so she's developing a bit of photophobia. And she's never had a headache like this before. So it's severe, and she's never had one like this before. She feels nauseated but hasn't actually vomited, and she just feels generally unwell but hasn't had any fevers, rigors, or kind of any other infective symptoms. The thing that's really concerned her and has concerned her family is that her right eyelid has become really droopy, and she's developing double vision in that right eye too. She hasn't had any recent head trauma, so she hasn't fallen off any bikes or anything like that. She hasn't banged her head. When you explore her past medical history, she can't really remember the name, but she knows that she's got cysts on her kidneys, and she takes ramipril, which is an ACE inhibitor, just 5 milligrams when she remembers to take it. So this is our history. So it's probably, obviously I can't type loads on the PowerPoint slide, but it's probably worth thinking about what are the diagnoses, thinking about some of the differential diagnoses here. So if you've got any thoughts, you can obviously share them, or you can pop them down on your bit of paper. So when you go to examine her, The first thing you note is that she looks in pain. So she looks objectively in a lot of pain. She's alert though, and her observations are not too exciting. She's a little bit tachycardic. Systolic blood pressure is a little high, but not too bad. Her airway's fine, breathing is fine, circulation is okay, but your crewmate looks at you, or your colleague looks at you and says, oh, is she fast positive? Her right eyelid's really droopy and her pupil's a bit dilated. She doesn't have any limb weakness though. She doesn't have any slurred speech, so the rest of your fast test is pretty normal. And everything else is normal. So you have a look, she hasn't got any rashes, no bruising or bumps to the head. Anyway, you look at this eye, and it looks a bit strange. So it looks something like this. It's a bit droopy. She's unable to open that eyelid, and the pupil's not really responding. So you shine a light in it, and it doesn't really respond. There's loads of people are typing stuff. So yeah, there's some good differentials here. And so we've got lots of differentials coming up here. People saying meningitis, stroke, migraine, TIA. Someone, however, has so some people are picking up on this eye, and could this be a cranial nerve problem? So you're heading along the right line. So this is a 46-year-old who's developed a sudden onset, worst ever headache, who is now presenting with a cranial nerve problem. So this history of the sudden onset, worst ever headache associated with a neurological deficit, in this case a cranial nerve problem, with a history of cysts on her kidneys, makes us really worry that this is in fact a subarachnoid hemorrhage. So some of you might know what a subarachnoid hemorrhage is. So there's two pictures here. So we've got a CT scan, and white is bone or blood, and black is brain. I'm not a radiologist, but that's a simple way to think about it. Anyway, what we can see here is we can see blood where it shouldn't be. So this white bit here, this is all blood, indicating a subarachnoid hemorrhage. And if you look, this is a pathology specimen, and this is looking at the base or the bottom of someone's brain. And you can see there's lots of blood filling what we call the basal cisterns here, due to a bleed in the subarachnoid space. So let's think about subarachnoid hemorrhage in a bit more detail. Why has this lady developed one? Why does she have a droopy eye? So as we've already talked about, subarachnoid hemorrhage is where you have bleeding into the subarachnoid space. And we won't go through the anatomy too much, but if you remember your meninges, you've got different layers, your dura mater, pia mater, arachnoid mater, and then you've got a potential space beneath the arachnoid layer. And the most common cause of a kind of a subarachnoid hemorrhage, a non-traumatic subarachnoid hemorrhage, sorry, is rupture of an intracranial aneurysm. So, or you might have heard it called a berry aneurysm because of what it looks like. So this is kind of around 80% of non-traumatic subarachnoid hemorrhages are due to a rupture of one of these aneurysms. Now, why do people get aneurysms? So it's an acquired process. So if you're a smoker, if you've got high blood pressure, if you've got a family history of aneurysms, you're more likely to develop these aneurysms. And the prevalence of aneurysms amongst adults, the figures vary depending upon which journal you read, but it's between around 1% and 3% of adults have an intracranial aneurysm. So for a lot of people, these aneurysms won't cause any problems, but obviously the risk is that it will rupture and you'll have a subarachnoid hemorrhage. Family history is pretty important. So, up to 20% of patients who have an aneurysmal subarachnoid hemorrhage will have a first or second degree relative with a confirmed intracranial aneurysm. So this is a disease that runs in families. Right, so we know a little bit about subarachnoid hemorrhage. We know where the bleeding is, we know where it comes from, we know some risk factors. Important to know, obviously, these are modifiable risk factors. So if you've got high blood pressure, we need to control that. If you're a smoker, probably a good idea to stop smoking. These will reduce your risks. So let's think about the droopy eye. So I don't really want to go too much into neuroanatomy, but this is a cranial nerve problem. So you've got 12 pairs of cranial nerves that arise from your brain and brainstem and control things like your eye movements, the muscles in your face, etc. And in this case, the cranial nerve we're interested in is what we call the ocular motor nerve, or cranial nerve number 3. And cranial nerve number 3 is responsible, it's part of your pupil reflex, and it's also responsible for kind of innervating or controlling your top eyelid muscle. Now, the way your anatomy is designed is if you have an aneurysm in a certain part of your brain, and in this case, it's a particular artery called the posterior communicating artery. So if you have a large aneurysm that forms there, then it can press on the ocular motor nerve. And therefore, you get this dilated, abnormal looking pupil with an eyelid droop, which we call ptosis. So an aneurysm from the posterior kind of communicating artery, and there's a couple of other arteries that can also cause this, might press on the ocular motor nerve. I think I've got an animation here just to show that. So you don't need to know about this in a lot of detail, but what I'm trying to do is I'm just trying to link some of the anatomy to some of the underlying clinical signs you might see. Now, don't panic at this slide. As I've said, neuroanatomy is no one's favorite topic. Maybe some of you are students and are revising such topics. It can be quite painful. I just wanted to very briefly talk about the pupillary light reflex, because it's very commonly taught, isn't it? I mean, you go on a first aid at work course and they start telling you about shining lights in people's eyes. It's very pervasive throughout medicine, this pupillary reflex. So let's think about this in a bit more detail. So the pupillary reflex is actually made up of two cranial nerves. So when you shine a light into someone's eye, it's your optic nerve that detects that the light is there. And then the optic nerve sends that signal to the back of the brain. And then the back of the brain decides, need to constrict the pupil. And then it's the ocular motor nerve, the third cranial nerve, and specifically the parasympathetic fibers of the third cranial nerve that go back to the eye and say, hey, pupil, you need to constrict. That's the easiest way I can think to explain it. For those of you that want to use more technical language, the optic nerve is the afferent pathway. So it senses the light, and the ocular motor nerve is the efferent pathway. So it causes an effect. So when you're shining a light into someone's eyes, you're actually testing their optic nerve and their ocular motor nerve. And in Our Lady, she doesn't have a problem with her optic nerve. She's got a problem with her ocular motor nerve because of a large aneurysm pressing on it. The other interesting thing about the pupillary light reflex is that you have both a direct and a consensual light reflex, because these fibers cross over in the back of the brain. So what do I mean by this? Well, if you shine a light into someone's left eye, their left pupil will constrict. That makes sense, doesn't it? That's the direct reflex. However, if you look at their right eye, you'll notice that their right pupil also constricts. That's the consensual reflex, because the fibers cross over. So if you don't believe me, you can, I don't know, grab a partner or your dog or other pet and have a look at their direct and consensual reflexes, and you'll see that, if you shine a light into the left eye, their right eye will constrict as well. So in Our Lady, because she's got a problem with her ocular motor nerve supplying her eye, she won't have a direct or a consensual reflex, because the ocular motor nerve is damaged and it's not able to tell the pupil to constrict. The other thing that you might be more familiar with is the idea of a blown pupil in the context of head injury, which is once again very, very commonly taught, whatever kind of medical training you do. So this is due to compression, once again, of cranial nerve number 3, the ocular motor nerve, but it's caused by raised intracranial pressure. And maybe you've got a hemorrhage due to a head injury, etc., an extradural hemorrhage, etc. So that causes your intracranial pressure to rise, and then your temporal lobe, specifically the uncus of your temporal lobe, herniates downwards, so pushes downwards, and it pushes on the third nerve, and that causes what we call a blown pupil, because the pupil will be unreactive. And this is a very bad sign, because if you're herniating your temporal lobe, then you're about to herniate other parts of your brain, compress your brainstem, stop breathing, etc. So that's, in case any of you are interested, that's the pathophysiology of a blown pupil. which is a very bad prognosticating sign in someone that's got raised intracranial pressure. Good, so that's my little mention of trauma there for all of you trauma junkies. I'm more of a medic myself. Right, so how do we know whether someone's got a subarachnoid hemorrhage? Well, these are your signs and symptoms to look out for. So the most important thing is that it's a sudden, explosive, severe headache, which we describe as a thunderclap headache. It reaches maximal intensity normally within 5 minutes. It might have been brought on by exertion, and it's diffuse, it's all over the head. Normally, it can be unilateral sometimes. And I put a picture of a baseball bat here because patients might describe it as being hit over the head by a baseball bat. So it's sudden onset, explosive, severe headache. You can get photophobia and neck stiffness, but this is often delayed. And this is because the blood in the subarachnoid space irritates the meninges. So you get those signs of meningism. So they're a bit photophobic, they might have neck stiffness. Around 2/3 of patients are going to have some form of reduced level of consciousness, because if you're bleeding into your head, your intracranial pressure rises, and that can push you into a coma. Likewise, seizures, and patients might have nausea and vomiting. You can get focal neurological deficits, like our patient had a third nerve palsy. You can also get patients who have a hemiparesis. And some of you might have seen ECG changes in these patients. So you can get these massive T-wave inversion, which is called cerebral T-waves. And you can get ST segment abnormalities. You can get ST depression, ST elevation. You can get prolongation of your QT interval as well. If you're interested in that, I'm going to pop some links in the CPD-me Facebook group for various things that I've talked about that I think are interesting. So you can go and look at some examples. Just going back to the ECG changes, this is a real diagnostic challenge, isn't it? Because if, let's say, your patient's had a massive subarachnoid hemorrhage, they've collapsed to the floor, they've got a reduced level of consciousness, you do an ECG, it's kind of horrible looking, ischemic-y looking. What do? You give them aspirin or other antiplatelet therapy. And that's the last thing you want to do in someone that's bleeding inside their head. So this is a real diagnostic challenge. Good, so we've talked about a bit of neuroanatomy, and we have talked about the signs and symptoms of the subarachnoid hemorrhage. So I've got a little patient quote for you now. So this is a real quote from a real patient, and I've kind of highlighted what we've just talked about in red. So this patient talks about the most excruciating pain, like an elastic band just went. So once again, that's going back to this is sudden onset, severe. She talks about snapping in her head and like an enormous amount of pressure. So these are some of the metaphors that patients might use. Anyway, some of you might recognize this quote. If you do, you've watched far too much TV. So this is a quote from Emilia Clarke, who plays Daenerys Targaryen, obviously in Game of Thrones. So I think she's had 2 subarachnoid hemorrhages and is now an ambassador for a brain injury charity. So this is her quote. I think she was giving an interview to a TV network about what it was like to have a subarachnoid hemorrhage. So that's just an example of a patient story. And it's also a really interesting example about the epidemiology of this condition. So we associate lots of things with older patients, but the thing with subarachnoid hemorrhage is that this is not a disease necessarily of older people. This is a disease of middle-aged. So this is from a study in Taiwan, which looked at, I think, about 600 patients who had a subarachnoid hemorrhage in their ages. And you can see here the mean age is only 55. And patients, it's not uncommon in patients in their 30s, 40s, 50s, etc., to have these subarachnoid hemorrhages. So be warned of the 50-year-old who presents with a sudden onset severe headache. Okay, that should make you really worry about whether this could be a subarachnoid hemorrhage. Right, so what are we going to do for this patient? Well, obviously you need to consider the diagnosis. So you should approach kind of anyone presenting with a severe headache thinking, could this be a subarachnoid? It's a time critical problem, despite the fact that most patients won't be what we call fast positive. So not many patients will have these focal neurological signs. Many patients might just have a headache, or have a headache initially and then deteriorate and go into a coma or have a seizure. You need to manage these complications, for example, seizures, obviously maintain the airway, prevent hypoxia, and this is all kind of reducing the risk of secondary brain injury. You know, there's not much you can do about the fact that they're bleeding inside their head, but you can correct other things that are going to reduce the risk of a secondary brain injury. In hospital, first line investigation would be a CT head, which picks up the majority of subarachnoid hemorrhages. However, if the CT is negative and there's still a strong clinical suspicion, most of these patients will have a lumbar puncture, so kind of where we take a sample of fluid from the subarachnoid space, but in the spinal cord, and we're looking for bilirubin, which is called xanthochromia. If patients are anticoagulated, so they're on warfarin, then we need to reverse that, and then we speak to our friendly neurosurgical colleagues about what they want to do. And it depends on lots of things: the anatomy, the functional status, you know, the performance status of the patient, about whether they're going to be suitable for surgery. Another medical treatment you might see used is nimodipine, which is a calcium channel blocker, because one of the complications of a subarachnoid hemorrhage is vasospasm. So you've had a bleed inside your head, your cerebral arteries go into spasm, they constrict, and then you have an ischemic stroke. So that's kind of double trouble, isn't it? So lots of these patients, in fact, pretty much all of them, will end up on nimodipine, quite high doses, in order to reduce the risk of vasospasm. Right, so this is the management, and we've talked about lots of scary things, like headaches are bad and it happens to young people. So you might be thinking to yourself, I'm never going to discharge or non-convey a headache ever again. And that's that's a fair worry. And certainly these patients, you know, when I see them, I always worry, am I missing something? So people have tried to come up with tools in order to detect subarachnoid hemorrhage, because a lumbar puncture is very unpleasant if anyone's ever had one, and a CT scan involves exposure to radiation. So this tool is quite interesting. It's called the Ottawa subarachnoid hemorrhage rule, and it's designed to rule out subarachnoid hemorrhage in non-traumatic severe headache. So there's a link to it, you can go and look it up. It's got very specific inclusion and exclusion criteria. But if you follow those criteria, it's very sensitive. So it won't miss a subarachnoid hemorrhage, but it's not very specific, so you can't use it for diagnosis. It's not a perfect tool. It's not a perfect tool, so you should always follow local guidelines and protocols. But it's just something else that you can use, maybe to rule out a subarachnoid hemorrhage in a very low risk patient. But once again, you can Google this tool, and there's a couple of blog posts of people discussing its usefulness. And I can pop the link in the Facebook group too. Good, so we've talked about subarachnoid hemorrhage. Let's move on to our second case. So case 2, back pain. Yeah, everyone else's favorite topic. You know, this is the patient you don't really want to see 20 minutes before the end of your shift, is it? So let's have a look at this in a bit more detail. So this is a 51-year-old man. Anyway, he's had a 10-week history of lower back pain. So at this point already, you're kind of, how can I say, rolling your eyes internally, which is bad. You shouldn't do that. So he's had a 10-week history of back pain. He's seen his GP twice. He's been prescribed naproxen, which is an NSAID, and some codeine. However, tonight the pain has significantly worsened, so he's rung 111. He describes the pain kind of shooting down the back of both legs. And last night, he's very embarrassed. He's sat on the sofa, and he describes he was wetting the bed last night, and he couldn't get out of bed because his legs were really weak. He was very embarrassed, so he didn't seek help. He's taken all the available analgesia, but the pains were still really bad, and he hasn't had any history of trauma, and he describes a bit of a strange sensation when sitting down. So he's in a lot of pain. His observations are normal, and his examination is pretty much unremarkable, apart from the fact he's got bilateral lower limb weakness. But he's in a lot of pain, so you're not really sure whether it's true weakness or whether he's just painful to move his legs. Okay, so you are all obviously amazing at this, because the question box, everyone has basically got this correct, which is good. I think there must be about 30 people that have got the right diagnosis here. So good, which is good that you know about this condition because it's really important to know about. So this man has obviously developed, well, he might have developed Cauda-Equina syndrome. He's got some red flags. He's got some red flags for Cauda-Equina syndrome. So we're going to talk about this a little bit because I think it's really important to know about. If you're in a role where you might assess a patient with back pain, you need to know about Cauda-Equina syndrome. You know, whether you're a first responder or whether you're working in a hospital, you definitely need to know about this. So Cauda-Equina syndrome, very briefly, is compression of the Cauda equina. So the Cauda equina is Latin for horse's tail, I think, which is a bundle of peripheral nerves that kind of it's the end of the spinal cord. We'll look at the anatomy on the next slide. And this compression commonly occurs due to a large central disc herniation, normally in the lumbar spine. So you can see on the diagram here, you can see it's a central disc herniation. It's a big herniation and it's compressing all of these nerves. Now this is slightly different. This is, well, it is very different to people that have what we call just a bit of nerve root irritation. So you might have gone to patients that have got a bit of sciatica, and what they've probably got is just a small herniation pressing on one of their peripheral nerves. So that's different to Cauda equina. Cauda equina is where you've got big compression affecting the whole bundle of these peripheral nerves, the Cauda equina. And the problem with this is it can lead to permanent paralysis and incontinence. So it's neurologically devastating for patients. It's really bad. So let's have a look at the anatomy. So your spinal cord, it kind of ends around T12, L1, L2, depends what textbook you read. So below that is the Cauda equina. It's the collection of peripheral nerves that go from kind of L5 to S5. And these peripheral nerves are really important. They supply sensation to your saddle area, so your groin, your perineum. They provide motor innervation to your sphincters, so your anal sphincter, etc. They provide innervation to your bladder and your lower bowel. So they kind of help you go for a wee, and they provide sensation and power to your lower limbs. So these are kind of quite important nerves. And then the most common cause of Cauda equina is obviously this large central lumbar disc herniation at the L4, L5 or L5, S1 level. Good, so we know what Cauda equina is. We know a bit about the Cauda equina. You need to know the red flags. So there's nice guidance on this, which I'll once again, I'll post. You know, if you're assessing patient with back pain, you need to know the red flags of Cauda equina, or you at least need to know to look them up. This is absolutely crucial. I've just copied these from the nice guidance. Kind of very briefly, if you've got bilateral sciatica, which makes sense because it's central herniation, if you've got severe or progressive neurological deficit of the lower limbs, if you've got bladder or bowel dysfunction, if you've got sensory loss, kind of saddle anesthesia or paresthesia, kind of perianally, perineally, or around your genitals, or if you've got laxity of your anal sphincter, these are all red flags for Cauda equina syndrome. And you need to think about how you ask your patients these questions. But if you just ask them whether they've got any bowel problems, they'll start talking about the constipation they've had for the last 6 months. You know, you're not very interested in that. So you need to ask them some quite specific questions. So for example, you could ask them whether they have any problems, you know, going for a wee. You could ask them whether they have any sensory changes when they wipe. These are quite specific questions, but they'll help you tease out these red flags. So it's really important you know about these. There's a quote, isn't there? The eyes cannot see what the mind doesn't know. So if you're seeing a patient with back pain, please make sure you look at these red flags. And whatever organization you work for might have their own red flags. Patients won't have all of these symptoms, and there are different subtypes of Cauda equina, which I'm not going to go through because it's a bit boring. But you can have varying levels of these symptoms. But if anyone with back pain has got these red flags, they need further assessment. So what further assessment would we do? Well, you need to consider the diagnosis, because missed Cauda equina is a significant cause of litigation. So we're paying out lots of money to people where we've missed Cauda equina, and for example, they are now have to use a wheelchair, they have urinary incontinence, fecal incontinence, etc. Obviously give them analgesia, and they need to go to an appropriate hospital. So you're Locally, you might have a cauda equina pathway because these patients require an urgent MRI spine, and ideally even out of hours. And for any of you that have worked in a small district general hospital will know we don't provide a 24-hour MRI service. The definitive management depends on exactly what's going on, but for lots of patients, it will involve decompression of whatever's pressing on the cauda equina. So you need to ring up the spinal surgeons and ask them to take a look, and they'll take lots of these patients and operate. And there's a little bit of evidence that the sooner you decompress the spine, the better the long-term outcomes. Okay, hopefully that makes sense. I don't want to scare you, but I'm just going to talk about the litigation in a bit more detail because this is quite interesting. Firstly, if you type cauda equina syndrome into Google, the first result is from a law firm asking, have you been affected by cauda equina? And they have a specialist cauda equina team who specifically deal with these cases. So just Google it, and lots of the first page results are law firms, because this is such a huge cause of litigation. So the statistics, they were very difficult to find, but the last statistics I could find were from around 2014, where it talked about the cost of compensation claims being about £68 million. So this is pretty bad. And obviously I don't want to scare you, but this is another case which is kind of a bit disheartening. So this is you can go to the BMJ link and read about this. I've removed his name because I feel really bad for this GP. Basically, he saw someone with back pain, and he wrote in his clinical notes, no red flags. And I'm sure we've all kind of done that. I'm sure we've all written no red flags for various conditions. Anyway, this patient did end up having cauda equina and I think was permanently disabled from it. And they brought a claim against the GP. Anyway, it went to the High Court, and basically the GP couldn't remember the patient and only had his notes to go off that said no red flags. And the patient and their husband argued that she did have red flags. I can't remember them specifically. And the High Court judge agreed with the patient because the doctor hadn't specifically written their examination findings, hadn't specifically documented that they'd excluded all of the red flags. So there's a little warning here for you about medico-legal aspects. So, and how you document red flags. And this is it's a kind of a sad case for everyone involved. And you can read the BMJ link, or I think it's publicly available if you want to read the full judgment. So what are the key messages? Well, the problem with cauda equina is that back pain is very common, but cauda equina is very rare. But if you miss it, it can result in severe morbidity. So you need to know the red flags and target your history and examination to cover these. You need to teach patients about red flags because they might not realize why their bladder or bowel, etc., is related to their back pain. So I really enjoy teaching patients. So spend 2 or 3 minutes with them and just talk them through very briefly why they need to seek help immediately if they, for example, develop incontinence or altered sensation around their groin, etc. And then accurate documentation is vital. You might see hundreds of patients with back pain over your career, and you won't remember them in 5 years' time when it comes to a claim. So make sure you've documented this carefully. Right, I'm conscious of time, so we'll move on. I just want to very briefly talk about something different but easily confused, which is malignant spinal cord compression, or MSCC. And I'm sure lots of you have been involved in these cases. So MSCC is not cauda equina. Although it can be a cause of cauda equina. So MSCC is compression of the spinal cord. Now remember, that's different. Remember, the cauda equina is after the end of the spinal cord, those peripheral nerve roots. MSCC normally affects the thoracic spine, so the true spinal cord. And it's usually caused by collapse or compression of a vertebral body. If you remember, you've got all your vertebrae that form your vertebral canal that your spinal cord runs through. And basically, if you've got a malignancy or cancer and it's spread to the bone and it's spread to the vertebra, then the vertebra can collapse down and it can compress the spinal cord. However, around 20% of cases of metastatic spinal cord compression, the patient doesn't have a history of cancer. So this is the initial presentation. The cancer has been completely asymptomatic until suddenly they develop this. And the problem is you can develop an unstable spine and obviously lots of neurological problems. So this is an oncological emergency because you can have catastrophic loss of function, similar to, a traumatic spinal cord injury where you come off your motorbike and you fracture your thoracic spine and it's devastating. It's kind of the same thing, but it's not trauma, it's destruction of a vertebra from cancer. It can cause a wide variety of neurological signs. It depends on the level of the compression. The main thing though is back pain. So patient with cancer with worsening back pain, that should make you worry about this. Most of them won't be able to walk, so 80% are unable to mobilize at presentation, and they can have a variety of problems with limb weakness, sensory loss. And some cancers are more likely to go and spread to your bone. So the main one that you might know about is prostate cancer. So prostate cancer commonly metastasizes to the bony spine. And because it's spinal cord compression, for those of you that do thorough neurological exams, if you don't worry, but for those of you that do neurological examination, because it's compressing the spinal cord, you're going to get what we call upper motor neuron signs. So they might have upgoing plantars and brisk reflexes, which is different to cauda-equina syndrome, which is because it's peripheral nerves, you would have lower motor neuron signs. So you wouldn't have any reflexes and you wouldn't have any plantar response. I'll post some stuff about neurological examination, but I'm not going to dwell on it. So what would we do? So most hospitals and oncology teams have what we call an MSCC coordinator. So it's someone that's dedicated to coordinating these patients. So maybe you might have a local referral pathway where you can contact the MSCC coordinator and get the ball rolling. NICE suggests that these patients are nursed flat because the spine might be unstable. You obviously need to give them appropriate analgesia. In hospital, they get a whole spine MRI. They get steroids in order to reduce the swelling. They get VTE prophylaxis, so to stop blood clots because they're lying in bed. Then the options depend on the patient. So either radiotherapy, some patients might unfortunately have to go for palliative care, or maybe surgical input. So if they're really fit and they are suitable, they've got good prognosis and they're functionally good, then neurosurgeons might take them and remove and fix the vertebra. For those of you that are interested, there are a couple of resources. So these have been produced in Manchester, these red flag cards for healthcare professionals. You can go to their website and I think you can order them. And then patients who've got high risk cancers like like prostate cancer might be given an MSCC alert card which warns them of the red flag features. So these are some really useful resources. Right, moving on. I'm conscious of time, but we've got one more case. So let's go through our last case. Hopefully you're finding this useful. I haven't bored you with neurology. Neurology isn't the most exciting topic, but we're trying to make it exciting. So a bit different now. So case 3, child with right hand pain. That sounds weirdly specific, but that's what it is. Okay, so let's go through this case. So this is a 5-year-old and his presenting complaint is sudden onset pain in right hand. So that's what comes through on your, I don't know, on your triage note, on your job description, whatever, that, sudden onset pain in right hand. And once again, your eyes roll. So he doesn't have any history of witness trauma, and the parents can't really think of any recent injury. He hasn't been causing problems on a trampoline or anything like that. He's really reluctant to move his hand or let his parents or yourself touch it. Really reluctant, kind of guarding his hand. And the parents have noticed some kind of small red spots visible on his hand and arm, but they haven't been able to get a good look at it. He developed a fever today, and his parents have given him a dose of Calpol 2 hours ago. He's just generally a bit rubbish, according to his parents, just looks under the weather. Now they're really worried because he was in contact with chickenpox 5 days ago. And obviously with this pain and fever and kind of spots, their parents are a bit worried that he might develop chickenpox. He doesn't really have any interesting past medical history. He's had all his jabs and doesn't take any drugs. So this is a bit different. So there's a couple of people commenting on the rash. Yeah, definitely. So rash and fever kind of makes you worry a bit, doesn't it? So he would be correct to worry. So he looks pretty unwell when you see him. He's withdrawn. He's got a temperature of 40 after this second dose of Calpol. He's peripherally rubbish. He's a bit shut down, maybe a bit mottled. You're not really sure. The light's not very good. He's got a prolonged central capillary refill time. And you have a look at this. You have a look at this limb, this arm, and he's got this small blanching red spots. Doesn't really have any photophobia, weak or limb weakness. His neck's fine. He's moving his neck around, absolutely fine. And you look elsewhere, and you can't see any non-blanching rashes. However, this is a febrile child with a new rash and with, signs maybe that he's a bit shocked. He's got poor circulation to his skin. So yeah, pretty much all of you have got the diagnosis here, which is good because I don't have much time left. Yeah, good. So what we're worried about here, febrile child, new rash, peripherally shut down and a bit shocked. What we're worried about here is meningitis, definitely. So there's enough red flags here to make us worry that this could be meningitis. And this is actually based off a true case, a true case, which I'll post the link once again, which was a very sad case where the diagnosis was sadly missed. So let's think about meningitis to finish off our evening. So obviously we know meningitis is just inflammation of the meninges. Anything that ends in itis means inflammation. So there's different causes. So the one we all worry about is bacterial meningitis. It's pretty rare, to be honest, but it's got high mortality and high morbidity. Viral meningitis, a lot more common, and it's often self-limiting unless you catch a weird virus or you're immunosuppressed. Some of you might have had viral meningitis if you thought it was a particularly bad flu and you had a bit of neck stiffness and a bad headache, you could have had a mild viral meningitis. Fungal meningitis, very rare in the UK. If you're on strong immunosuppressive medications, then you can develop a fungal meningitis. And there's other causes, so some drugs and malignancies can cause inflammation. And they all kind of have relatively similar clinical presentations. You're not going to know from a brief assessment whether they've got bacterial, viral, or fungal meningitis. So obviously what we all worry about, obviously, is bacterial meningitis, isn't it? So that's pretty simple, isn't it? It's just inflammation of the meninges due to a bacterial infection. So I'm not a microbiologist. I don't find this particularly interesting, but we should just talk about the causative organisms. So the one that you've probably heard of is Neisseria meningitidis, and that causes meningococcal disease. So just to clarify the terms, meningitis is any form of inflammation of the meninges. Bacterial meningitis is inflammation of the meninges due to bacterial infection. And then meningococcal meningitis or meningococcal disease, etc., is infection by Neisseria meningitidis, which is a bacteria that causes meningitis. Okay, hopefully that makes sense. But there's a couple of other causative organisms, Streptococcus pneumoniae and Haemophilus influenza type B or Hib. And you might recognize these because this is what we vaccinate against, isn't it? So you might have heard in the news about ACWY. Yeah, you might have heard that. So that's ACWY are different subtypes of Neisseria meningitidis. I think there's 12 in total. So that's a vaccine designed to stop various subgroups of Neisseria meningitidis. I think we vaccinate against Streptococcus, and we definitely vaccinate against Haemophilus influenzae. I think since the early 1990s. So that's quite rare. Although obviously more people are not vaccinating their children. Bacterial meningitis is bad because high mortality, high morbidity too. So you might recover, you might live, but you might be left with significant neurological complications such as seizures and hearing loss. You might have been to patients, older patients who, when meningitis was a lot more common and they've got hearing, maybe they have seizures or hearing problems due to complications. So a nice boring table for you from Public Health England. So this BCWY are the subgroups of Neisseria meningitidis. And this is data, quite recent data. I think this is last year, October to December 2019. Just breaks it down by age and by the subtype. So you can see that in the UK, meningitis B is the most common. The other really interesting thing about this graph is we all associate it with young people. But there's a sizable proportion of people over the age of 40 who are catching bacterial or who are getting meningococcal disease. So that's just interesting. So it's not just a disease of young people. Right. How do we know if someone's got meningitis? So not many patients have the classic triad of fever, neck stiffness, and photophobia. I think less than 50%. It's got a very variable presentation. Older patients, for example, might just present with confusion. Patients can have seizures if the actual brain tissue itself is inflamed. The rash is, we've all heard of this rash, haven't we? It's kind of mostly associated with meningococcal disease, so infection by Neisseria meningitidis, but it's a very late and variable sign. So the first thing to say is young children don't display evidence of meningism, so photophobia and neck stiffness, as much as adults. So young children may not have the classic photophobia and neck stiffness. The other thing to say is the early rash of meningococcal meningitis may be blanching in up to 30% of patients. So I'm forever, well, when I worked in the pediatric kind of A&E, I was forever explaining to patients, you know, this glass test, just ignore it, okay? I'm not interested, really. If they've got a rash and you're worried about a child, they need to come in. We need to see them, because around a third of patients might have a blanching rash. And the worst thing would be for a parent who's worried about a child to be falsely reassured by doing, you know, the tumbler test and, oh, the rash is blanching, I don't need to worry. So if they're worried about a child and they've got a rash, come and see us. And the appearance of the rash is really variable. So these patients, you need to strip them from head to toe. You know, you need to look everywhere. Okay, under nappies, if they're that young, clothing has to come off. Don't just do a cursory look of the arms, the legs, and the neck. Okay, search them from head to toe and make sure you document that in the notes. Yeah, so definitely search them. So let's think about meningococcal disease in slightly more detail. So remember that's disease caused by Neisseria meningitidis. So this is a great kind of study from the Lancet in mid 2000s, which looked at what symptoms or signs, sorry, or we should call them clinical features, did patients or children have with meningococcal disease. I think this was nearly 500 children that they looked at. Anyway, there's some really interesting statistics here. So you can see only 60%-ish had a hemorrhagic rash, okay? So around a third didn't have a rash. You can see that only 35% had neck pain or stiffness. So the majority of patients did not have neck pain or stiffness. Even less had photophobia, okay? Most patients had a fever, and drowsiness was quite a specific sign too, with other things such as irritability. Now, the other really interesting thing about this graph is they looked at the median hour of onset. So as the disease progresses, you get different signs and symptoms. So you can see that most patients, the first thing they got was a fever, and then they had some nausea and vomiting and then some irritability. But the median hour of onset for this rash was 13 hours. So the rash is happening much later on. Neck pain and stiffness, 13 hours, so much later on. And photophobia, 15 hours, once again, much later on. So the take-home message from this is that the non-specific signs, such as fever, drowsiness, nausea, and vomiting, they happen much earlier in the disease. And it's only once children are really much sicker that they're going to develop these, you know, spot diagnosis signs that we all read about in textbooks. And just to pick up, this child had limb pain. Well, he had arm pain, didn't he? So around nearly a third of patients developed leg pain. I don't know whether they looked specifically at arm pain. I don't think they did. But so limb pain can be a presentation of meningococcal disease. So it's always worth thinking about that. And there's a couple of interesting case reports out there about febrile children who have a limp or who refuse to walk, ending up having meningococcal disease. So this is a really interesting slide. Go and read the whole journal article. It's quite easy to read, and it talks about the clinical features. And this study has helped inform some of our red flags, so cold hands and feet. You might have seen that in some of the warning leaflets we give out to patients. It probably came from this study. So the key message is don't wait for the rash. Yeah, don't wait for the rash. So just to finish off with, I'm not a pediatrician, but just in case anyone hasn't seen this before, if you're assessing febrile children, you really need to know about the NICE traffic light system for identifying the risk of serious illness. This is an excellent tool for a non-pediatrician. It's really good. Makes it pretty easy to support your decision making, whether to send the child home, leave them at home, speak to a pediatrician, or kind of take them to A&E. So have a look at this. It's really a really good tool. Sorry. It's really good, especially for if you don't have much pediatric experience. And maybe your local organization has got various, might have adapted this, but this is the traffic light system. And then the other thing you might have heard of is the pediatric assessment triangle, which I think came from the US. I think they started teaching it on APLS courses, which is a hands-off assessment. So you don't have to touch the patient to decide, do they look sick or not sick? And once again, this is just an interesting tool to support your decision making. I'm sure lots of you have seen this before. It's kind of quite useful. You look at a patient and you just think, oh my God, they look terrible. And it's probably the pediatric assessment triangle that you're going off here. So what's their appearance? What's their work of breathing like? And their circulation to the skin. So if you remember in our case study, our 5-year-old, he was pale and he had some mottling. So already he's got evidence of compromise in the pediatric assessment triangle. There's a great pediatric education website called don'tforgetthebubbles.com, which I really enjoy. And they've got a great article on the pediatric assessment triangle if you want to learn about it in more detail. Right, we're nearly there. How are we doing for time? Okay, a little bit over. So you need to suspect the diagnosis. Don't be reassured by the absence of a rash. You need to manage and treat any complications. So you might not carry antibiotics pre-hospitally unless you're at a certain skill level, but you can obviously manage seizures, correct hypoxia, etc. I think, I'm not au fait with JR Calc in a lot of detail, but I'm pretty sure pre-hospitally you probably carry benzyl penicillin if you're a paramedic crew, and certainly most GP practices, if they've got a febrile child with a funny looking rash, they'll probably be jabbed with intramuscular benzyl penicillin. And it's obviously time critical. It's definitely time critical, and you need to let the receiving hospital know. Kind of in hospital, they get resuscitation, broad spectrum antibiotics, septic screen, a lumbar puncture. So that is, if you're thinking earlier, how do I know if this is bacterial? How do I know if it's viral? How do I know if it's weird fungal infection? Lumbar puncture is your key. So lumbar puncture will tell you kind of what's going on, and you might even be able to grow an organism. So you send it off. You can send it off to the lab, and they'll see if they can grow something. And sadly, lots of these children will require some form of intensive care input for organ support. Fine, good. I guess the only other thing to say, which I haven't put on the slide, is about the importance of safety netting, And I'm sure I talked about this in the last talk. But if you think back, most children develop these non-specific symptoms. They have a bit of a fever. But we can't admit every child with a fever to hospital. We can't admit them all to the pediatricians. We can't do a lumbar puncture on every febrile child. That wouldn't be sustainable, would it? So I think it's really important that we safety net. And we explain to patients, at the moment, there's nothing to worry about. Well, no, explain to parents, don't we? The child probably won't understand. So you really need to safety net and say, there's no red flags at the moment, but make sure you educate all of the parents you meet about the warning signs to look out for. Because if you see this disease at the very early stages, the child might look relatively well and they might not have any red flags, and you may well make an accurate assessment to leave them at home, but it's absolutely crucial to safety net and safety net well. Right, okay. So we have gone through kind of 4 neurological emergencies. So hopefully you feel a bit more confident in recognizing and managing these neurological emergencies. I put a topic list here. So we went through kind of subarachnoid hemorrhage, cauda equina, metastatic spinal cord compression, and meningitis. So, I kind of chose these because I think they're quite important conditions to know about. And I find a lot of the time people think neurology equals stroke. And so we haven't talked about ischemic stroke because I think that's taught a lot. So these are some other neurological conditions. And if you've got any kind of specific questions, you can always email me. I had a few people email me after the last talk, and that's absolutely fine. Otherwise, I think we've got a little bit of time for questions now. Is that right, Tom?
So we've had quite a few questions, Chris, and thank you once again for such a great session and the 4 cases that you've run through. I'm just going to start off and working our way through the cases in sort of a logical order, really. And our first question is from Daniel. And Daniel's asking, do you have a moment to describe the causal link with renal cysts and SAH, please?
Yeah, so it's kind of a known association that if you've got polycystic kidney disease, I'm not sure, you might have heard of autosomal dominant polycystic kidney disease, or ADPKD, which is a kind of an inherited condition where patients develop cysts on their kidneys, and then they can develop renal failure, hypertension, etc. And then for some reason, which I'm not sure is known, I don't know off the top of my head, but you develop cysts in your kidneys, but that disease process somehow is similar in your intracranial arteries. So I kind of explain it to students. You develop cysts on your kidneys and you develop cysts in your brain, which is probably a gross oversimplification, but that's the way I think about it. So they're more prone to developing the aneurysms. Now, remember, that's just developing the aneurysms. So you might have autosomal dominant polycystic kidney disease and never have a subarachnoid hemorrhage, because lots of people that have aneurysms, they don't rupture. But obviously, if you've got aneurysms, it increases your risk of a subarachnoid hemorrhage. I'm afraid that's the limit of my knowledge on the link between polycystic kidney disease and subarachnoid hemorrhage.
Oh, thank you very much for answering that, Chris, and thank you, Daniel, for that question. So our next question is from Matthew, and Matthew is saying, in terms of reversing anticoags in vitamin K, is vitamin K enough if INR is in therapeutic range, or escalate for octoplex?
Well, see what the neurosurgeons want to do. That's my main advice, because we reverse anticoagulation. Obviously, it's kind of for two reasons, isn't it? I mean, it's you want to stop the bleeding, but really it's because they might require a craniotomy or some sort of endovascular procedure. So it's kind of up to the neurosurgeons what if they're going to perform an intervention, what kind of type of anticoagulant, kind of what level they want to aim for. I mean, if your INR's in, well, when you say therapeutic range, it depends, because if your therapeutic range is 2.5 to 3.5, that's far too high for them to consider doing something like a craniotomy. So they would probably want large dose of vitamin K. Octoplex kind of depends on your local protocol. Often you have to ring the hematologists because it's very expensive. Most places have some sort of protocol for this. Remember though, it's not just warfarin. Lots of patients now are on these DOACs, aren't they? So these rivaroxaban, apixaban, dabigatran, etc. So those are a bit more difficult to reverse. There are some specific reversal agents. And so that's definitely where you probably want to speak to your hematologist. But also, another problem is antiplatelets. So I've certainly seen a patient who had a subarachnoid hemorrhage and was in pain, so took 600 milligrams of aspirin. And when I spoke to the neurosurgeons, and they were very reluctant to do any form of operative intervention because of the large amount of antiplatelet agents on board. So remember, it's not just kind of warfarin. There's other drugs you need to ask about in the drug history.
Super, thank you very much for answering that, Chris, and thank you, Matthew, for that question there. Just moving on to the cauda equina case that you went through secondly. So what effects, would you alert a suspected cauda equina to the hospital? We tried to, and the alert was not accepted.
Yeah. Well, okay. So I mean, it depends on your local policies. So maybe you might have a cauda equina flowchart where you can ring the orthopedic team or the neurosurgical team. I think this is more a question regarding local politics probably, but you might be able to have some form of pathway to alert the receiving team. As for pre-alerting the emergency department, I'm not sure that's necessary, because kind of the purpose of a pre-alert isn't it? It's kind of to let it's for patients that require aggressive, urgent resuscitation. We need to clear a bed in the resuscitation area, or we need to set up for a particular procedure. So they need a chest drain, they need this, they need that, etc. So cauda equina it is an emergency, but it's not kind of an emergency that would be rushed straight into a resuscitation area. It would be, it's an urgent condition. They would need a rapid assessment, a discussion with a senior doctor, consideration of an MRI, but I'm not sure that a pre-hospital pre-alert is necessarily always going to be required. Yeah, that's my thoughts. I mean, I don't work pre-hospitally, but someone might disagree with me, but that's my thoughts anyway.
No, that's really appreciated. Thank you very much, Chris. And thank you for that question as well there. Just moving on then to another question from Matthew. And Matthew is saying, I've attended a few incidents where MSCC has been present due to secondary cancers, and the requesting GP or HPC has asked for spinal immobilisation. Is there any benefit in this type of treatment? And how do you suggest this group of patients be handled, moved, or immobilised?
Okay, that's a great question. So that is a great question. I've actually had the same a long time ago. I did some voluntary ambulance stuff. I definitely remember doing a job just like this. So I'll try and be brief because there's lots of evidence around spinal immobilization that I don't know off the top of my head. But the worry is that these patients can have an unstable vertebra. So in the same way that you fall off your motorbike and you break your back and it's unstable, the risk of movement is that it moves the vertebra and damages the spinal cord. Now, it's the same worry in MSCC, except there's no history of trauma. It's because the vertebra has been destroyed by a cancer. So the NICE guidance says these patients should be nursed flat, and it's quite specific. It says that they should be log rolled and they should use a bedpan, etc. So that's what the NICE guidance says. It's quite clear on that they should be nursed flat. In the pre-hospital environment, I think that's a lot more challenging, isn't it? You need to do a bit of a risk assessment. So if they're up the top of several stairs, it's going to be quite risky, isn't it, to shove them on a scoop and carry them down the stairs? That's quite risky, isn't it? So I think you need to make a balanced risk assessment, try and minimize movement, try and keep them as flat as possible, but that's not always going to be possible. You've got to remember that, how did the patient get to the GP surgery? They might have driven or probably been given a lift or taken a taxi. They probably might have walked into the consultation room. So I think as long as you justify your decision making, you'll be okay. As for the use of any form of immobilization equipment, I'm not sure. I don't know really if there's any evidence that gives you any benefit at all. The exception to that might be if they've got some form of unstable cervical vertebra, then the neurosurgeons will sometimes ask for them to be in a hard collar. But that's based on neurosurgical advice. So unless you've got any protocols, my main advice is, try and keep them as flat as possible. The other problem is that lying flat is really painful if you've got metastatic spinal cord compression. It's one of the features. If you lie flat, it makes the pain worse. So unless you've got some good analgesia on board, you might find that your patient won't tolerate that and would much rather be in a semi-recumbent position.
Super. Thank you very much for answering that, Chris. And thank you, Matthew, for that question there. Really great question. And just going to finish up with a final 3 questions before closing off tonight. I'm sorry if we can't get through all of the questions tonight, if we're not able to get to yours. We will be passing them through to Chris. And Chris, are you happy to answer them offline and I'll pass the responses through?
Yeah, or just email me, yeah.
Yeah, super. Okay, so our third to last of the evening is from Robert. And Robert's asking, are there any specific blood tests required for each of the conditions discussed tonight?
Okay, it's quite a broad question. By specific blood test, if you mean, is there a single blood test that diagnoses the condition, then the answer is no. But there's not many blood tests that give you an exact diagnosis. Kind of very briefly, the purpose of blood tests is kind of to provide a baseline, isn't it? And to rule out other diagnoses. Obviously, in the meningitis case, the blood tests are going to show you a raised white cell count, a raised CRP, which is evidence of inflammation. Your patient, if they're shocked, then they might have started to develop an acute kidney injury. So you might have U&E derangement, and they might have kind of other electrolyte abnormalities as well. Your subarachnoid hemorrhage patient, probably one of the important things to do is a coagulation screen if you're worried about whether they've got any anticoagulants on board. They can develop abnormalities in sodium, so they can kind of develop sodium problems. So that's why you would do a U&E, but there's no kind of specific blood test that I'm aware of. I think people are trying to develop one, but off the top of my head. And then metastatic spinal cord compression, it depends really on the patient's history. One of the specific kind of features that you get. If you've got cancer in your bone, then you can become hypercalcemic. So if we did a bone profile, your calcium might be up. And the other thing is you've got something called ALP in your bones as well. And you might have heard of ALP. It's actually part of a liver function test, because you also find it in the biliary tree. So people that have got biliary problems, you know, gallstones and or a stone stuck in their common bile duct might have a raised ALP. But the other place you find ALP is in the bone. So, you know, if we did a liver function test on them, we might find a very high ALP, and that would lead us to worry that they've got some form of malignancy in their bone. But as I said at the beginning, like most blood tests, it adds to your clinical picture, but it's kind of not a spot diagnosis.
That's brilliant. Thank you very much, Chris. And thank you very much for asking that question there. So our second to last question of the evening, this is from Steve, and Steve's asking, was it a neurological cause for the hand weakness in the meningitis case you discussed?
Good question. Depends how you define neurological cause. If I think what you mean is there like a nerve problem? I think that's what you're saying. The answer to that's no. So the pain is kind of it's a feature of sepsis, isn't it, or septicemia? So, and the pathophysiology isn't completely understood, but you get I think it's a combination. You get local inflammation, you get microvascular infarction, and then they develop limb pain. So like we said, most commonly in the leg, but our patient had it in the hand. But there's not kind of like you know, they've damaged a nerve in their neck, or the meningitis has affected a nerve in their neck and it's causing arm pain. It's kind of a reflection of their general inflammatory state due to having an infection.
Fantastic. Thank you very much for answering that second to last question there. And our final question is from Ben. Ben's saying, great session again. And can you suggest some good resources for learning on how to carry out more through neurological assessment?
Yes, I can. I've actually got, so the best resource I think anyway, is it's called Geeky Medics. I'm sure some of you have heard of this, especially those of you who have practiced for OSCEs. So geekymedics.com, which was originally set up for medical students. So it was set up for medical students about 10 years ago, but it's become a great resource for any healthcare professional, student healthcare professional. And what's really good about it is their examination section. So they've got text, you know, they've got articles, how to examine the lower limbs, how to examine the upper limbs, but they've got a series of really good videos, which are also on YouTube too, which walk you through OSCE style, how to perform an examination. But they're high quality videos. They show you exactly what tests you can do. So I really recommend Geeky Medics because it's a good resource, but it's not too complicated. It's designed for generalists or for students. So it's some of the neurological resources out there. You know, you read the third sentence and you've got no idea what's going on. So yeah, Geeky Medics is my best advice.